Hello, my name is Sean Tigg and I'm a radiologist at Indiana University School of Medicine. In this short, approximately 10-minute presentation, I'll talk about the CT radiation biology, specifically related to chest CT scans. It is estimated that approximately 6,800 future cancers will result secondary to chest CT scans performed in 2007. Up to 2% of all future cancers in the United States will actually result from CT scans performed. Therefore, medical providers need to become familiar with dose reduction strategies and feel comfortable discussing the risk of radiation with their patients. When a CT scan is performed, electrons are released when the X-rays hit living cells. This results in direct mutation of the DNA. In addition, there are harmful oxygen species which are released secondary to ionization of water molecules within the cells. Most DNA damage is repaired rapidly. However, if there is persistent damage, loss of function, necrosis, or malignancy may develop within the cells. Stochastic effects are the major concern with the doses received during diagnostic medical imaging. Diagnostic medical imaging has a low linear energy transfer, less than 100 millisieverts. The stochastic effects are unpredictable and random. They have a long latency, at least 5 years, and often greater than 20 years. The most significant risk is cancer. The risk of heritable defects from damage to germ cells is negligible. And younger females are at increased risk because of greater proportion of actively dividing cells and have longer lifespans for malignant transformation to occur. Deterministic effects really don't apply to the levels of radiation received during diagnostic medical imaging. Rather, these effects apply to high doses of radiation received during radiation oncology. There is widespread cell death, and the cell death usually occurs within days or weeks of exposure rather than the long latency seen with stochastic effects. So at the levels of radiation received during medical imaging, the risk of cancer is felt to follow a linear no-threshold model. This means that the dose and cancer risk are related in a linear fashion. There is some risk even at minimal doses, and there is incremental risk with each exposure. While the risk is small, it is statistically significant. We're not exactly sure how the incremental risk increases. It may be directly additive. The general thought is that the risk of 2 CT scans is double that of the risk of 1 CT scan, regardless of the time interval between scans. This data is extrapolated from atomic bomb survivors and nuclear power plant workers. The one thing to keep in mind is that these groups are slightly different than the medical imaging group, in that the medical imaging group does not receive whole body acute exposure. The mean exposure for atomic bomb survivors was 40 millisieverts. This is equivalent to approximately 4 to 6 chest CT scans. In medical imaging, the risk of cancer may not significantly increase above the baseline risk for humans. There is a longitudinal study underway within the UK looking at approximately 250,000 patients, which will hopefully help us answer this question. Clinicians may be less concerned about ordering more scans as a patient ages because of the shorter lifespan remaining and therefore the overall feeling that there is a decreased risk of cancer. The risk of lung cancer may be this one exception to the rule related to age and cancer risk. Other cancers such as lymphoma and breast cancer have higher risk when exposed at a younger age. However, with lung cancer, there appears to be a higher risk of lung cancer when the radiation exposure occurs at an older age. This is felt to be secondary to the synergistic carcinogenic effect of radiation and tobacco smoke. So this makes us wonder, what about lung cancer screening, given that we might actually be placing the patients at increased risk in these older patients? CT has revolutionized disease management within the population. In fact, it is the most used and fastest growing imaging technology. You can see here the rapid growth between 1993 and 2007 of the utilization of CT scans. In fact, CT scan utilization grew at a rate 10 times that of the U.S. population growth. In 2006, approximately 17% of CT scans included the chest. This is very important because chest CT scans include radiation exposure to the thyroid, breast, and lungs, which are all highly susceptible. Medical radiation has now replaced background radiation and is now the primary source of population-wide radiation exposure. There are younger patients where the risk may outweigh the benefits of radiation exposure. Risk-benefit analysis are often difficult. There are decision aids such as ACR Select, which is based on the ACR appropriateness criteria, which can help weigh the benefits and risk of performing an imaging procedure. However, these are often underutilized. In order to minimize radiation dose not only to a specific patient, but to the overall population, it is necessary to determine if an imaging study is truly indicated, which is the appropriate study that will give the most information that will best benefit the patient. How do we reduce dose during the actual examination being performed? And then how do we report and record the dose so that we know what the cumulative dose to the patient is? It has been determined that between 1/4 and 1/2 of all CT scans are ordered inappropriately. Clinical decision support is being incorporated into physician order entry to help decrease the number of inappropriate studies ordered. In addition, there are focused educational programs as well as national campaigns such as Image Wisely and Image Gently, which are being promoted to help educate physicians on the appropriate use of medical imaging. Wide variations in the protocol also exist across multiple institutions across the country. The ACR Facility Accreditation Program will hopefully create more standardization and result in an overall lower radiation dose, trying to achieve the as low as reasonably achievable radiation exposure. Patients who would like to monitor their overall radiation exposure have multiple mobile applications and websites which can be utilized to keep a log of the radiation exposure. However, as you can imagine, this is only going to be utilized primarily by motivated patients. There are some new institutional dose logs. However, the problem here is when patients receive their medical care at multiple healthcare systems. The FDA has recommended that CT scanners have the capability to alert technologists if safe doses are exceeded. You might think it is too late for the CT scanner to warn the technologist about the radiation dose level. However, the scanner can actually predict the dose prior to the actual performance of the scan. So if the technologist is alerted, they can adjust the parameters prior to the scan and actually perform the scan of the patient at a safe dose. There are also centralized dose registries such as the DIR, the Dose Index Registry from the American College of Radiology. Facilities compare their CT dose to regional and national values. They receive periodic feedback based on body part and exam type, and eventually the data will be utilized to create a national benchmark for CT dose indices. As always, it's a delicate balance between the radiation dose the patient receives and the image quality. There are patient factors such as patient size and body habitus, which determine the radiation exposure. Different regions of the body also have different susceptibility to radiation, depending on the organs being exposed. There are different technical factors that also contribute to the radiation exposure. In general, a standardized protocol such as that highlighted in the pink box is selected. And then on an individual basis, parameters which are highlighted in blue can be changed. These specific parameters include tube voltage, tube current, the table speed, the gantry rotation time, the scan length, the image thickness, and if we apply iterative reconstruction. Most scanners have the ability to modulate the tube current based on the body habitus. Therefore, if there's less soft tissue, such as in the lungs, the radiation dose is decreased, whereas where there's increased soft tissue in the abdomen or where there is significant bone, such as the shoulder or the pelvis, there's a significantly higher radiation exposure. KVP can be reduced to reduce the overall radiation exposure to the patient. The advantage of this is that there's also an improvement in the contrast to noise, secondary to a kVp that is closer to the K edge of iodine. Iterative reconstruction is now being routinely applied on modern-day scanners. This significantly reduces the radiation dose to the patient while overall increasing the image quality. This is now possible secondary to the significantly more powerful computers that we now have to reconstruct the images. Just a brief word about breast shields. Breast shields should not be utilized. The AAPM recommends not using them because of the disadvantages, and there are other techniques which can result in the same desired effect with better results. Other techniques include angular tube modulation, which decreases the dose in the AP direction to reduce the overall dose to the breast. You can still use bismuth shields for thyroid and gonads. Thank you for your time and attention. Hopefully this has helped you better understand radiation related to CT scanning.